Hi, I'm Mark Shiroishi, and I am the Director of Brain Tumor Imaging here at USC. And I'll giving an overview of the brain tumor imaging we have at the USC Brain Tumor Center. So this talk will outline some concepts regarding brain tumor diagnosis and how we use neuroradiology to help the doctors figure out what kind of lesion you have. And then we'll be talking about some details about post-therapy monitoring and some of the unique aspects of that and pre-surgical planning imaging that we have in order to personalize your brain tumor imaging here at the USC Brain Tumor Center. So first we'll be talking about brain tumor diagnosis using neuroradiology. There are certain basic concepts that have stood the test of time, including information about a patient's age, the location of the lesion, and the imaging appearance. Here we have two slices from a CT scan in a 68-year-old female who presented with headache and seizures. Now, CT scans are very often the first imaging modality that patients will undergo, especially in the acute setting. CT scans are easily attainable. They are available in emergency rooms 24/7. This is opposed to MRI scanners, which may not always be available around the clock. And so CT scans are a very important initial imaging step that a patient would need to undergo in order to make sure that they don't have anything emergent going on. So in this case, you can see that the patient has a lesion on the right side of the patient's brain. Now, if you can see in these images that the right side is actually on the left side of the image, that's just an imaging convention, and then you could see that the right side of the image actually is the left side of the patient's brain. So when I say right and left, that's sort of the imaging convention that we'll use. But on the right side of the brain, you can see this hyperdense, pretty well circumscribed mass that has some sharp borders, and it is hyperdense or hyper-attenuating compared with the density or the attenuation of the rest of the brain. So it appears a little bit brighter. One slice up on the image to the right, you can see that there are some very bright areas or hyperdense or hyper-attenuating areas that correspond to calcifications. Another important aspect of this is that it looks like this tumor is arising from outside of the brain and actually pushing into the brain rather than arising in the brain. So in that case, we call it extraaxial. If a lesion is arising from inside the brain, we refer to it as intraaxial. In this case, we have an extraaxial mass that looks well circumscribed and is partially calcified. And given that this is an older patient, this seems most consistent with a meningioma. Meningiomas are benign tumors, generally speaking, that are not usually very aggressive and can be dealt with in a pretty straightforward manner, and patients are usually cured of the tumor after surgical resection. Although sometimes they can appear in more troublesome areas, and those are more complicated cases. But by and large, tumors like this can be can have a relatively good outcome. So after the initial head CT, if there's concern for something going on, in that case we definitely saw what looked like a meningioma, patients will go to MRI. And with MRI, that is the test of choice in neuroimaging, particularly with regard to the imaging of brain tumors. And as you can see in the top left image, that is a T1 weighted image, where you can see that the white matter, which is the structure of the brain that is more central, is brighter or more hyperintense than the gray matter, which is overlying the white matter in the cortex, which is a bit darker or hypointense. And you can see the meningioma or suspected meningioma that we see overlying the right frontal cerebral hemisphere convexity, and it looks very well circumscribed, sharp borders, and it looks definitely extraaxial. The image below that on the bottom left, that is after the administration of a contrast agent. We often will give a contrast agent to make sure that the lesion doesn't enhance or may enhance, and the characteristics of the enhancement pattern can also help differentiate different types of lesions. In this case, meningiomas characteristically have uniform contrast enhancement, are generally uniform on T1 weighted imaging, as well as on T2 weighted imaging, which is the bottom right image. Now, T2 weighted imaging is also very helpful because it gives an idea of the composition of a lesion, and you can see also that the imaging characteristics of a T2 weighted image are quite different from that of a T1 weighted image, in that the white matter is relatively darker than the cortical gray matter that we see, and it's actually the opposite of T2 weighted imaging. In the upper right corner, we see a T2 weighted flare imaging. A flare image is a T2 weighted image where the cerebral spinal fluid, that bright stuff that you see in the sulci of the brain, the folds of the brain, in between the folds, that's the cerebral spinal fluid that bathes the brain and the spinal cord. On T1 weighted imaging, it's dark, but on T2 weighted imaging, it's very bright. Flare imaging is T2 weighted imaging, but the fluid is made dark. And so in that way, it really accentuates the contrast between the brain and the CSF and the ventricles and the sulci. Flare imaging is very helpful because most pathologies that affect the brain are hyperintense or are bright. And if you just look at T2 weighted imaging, it's possible that if you had a relatively small lesion, that if it's right next to the cerebral the very bright cerebral spinal fluid, you may not see it very well. So doing flare imaging is quite useful, and so that's one of the first things we go to. We look at the flare imaging, and then we look at the pre and the post-contrast enhanced T1 weighted imaging to characterize this. And this, all the imaging characteristics here are consistent with a meningioma. Also, on the T1 weighted post-contrast enhanced image on the bottom left, you can see at the very anterior and posterior aspects of the lesion, you can see a little area, what we refer to as a dural tail. A dural tail is a relatively unique hallmark of meningiomas, and it's highly suggestive of that. And in this case, this turned out to be a meningioma, and the patient did quite well after surgical resection. Now, the next case that I'm going to show you is a little bit different and a little bit more difficult in its treatment and the outcome. In this case, we have a 60-year-old male who had presented with a headache, and we see that we have an MRI image on the very left here. That is a T2 weighted flare image, and in the right temporal lobe, situated more centrally in the white matter, is a hyperintense lesion, and it looks mass-like. And there was concern that this could be a low-grade glioma. There are other things that potentially can look like this, some infection and inflammatory conditions, but a glioma was a big concern based on the location and the age of the patient. And you can look in the center image and in the image to the right, the pre and the post-contrast enhanced T1 weighted image, that the lesion does not really enhance. Unlike the meningioma that we saw on the previous scan, the image shows that it doesn't really light up on the post-contrast enhanced scan, so that really doesn't enhance. And as opposed to an extraaxial lesion with a meningioma, this is an intraaxial lesion because we could see it's clearly arising from the substance of the brain itself. And because it didn't really enhance, the consideration that was that this could be a low-grade glioma as opposed to a high-grade glioma. High-grade gliomas usually demonstrate some contrast enhancement, but there are some high-grade gliomas that can demonstrate very little contrast enhancement. So this was followed up with imaging, and then 3 months later, as you can see, that lesion started to get a little bit bigger, and it was even more concerning for a low-grade glioma. And so then it was decided to undergo surgical resection to relieve the symptoms and also established a histologic diagnosis. And you can see there's a big cavity now where the surgical resection was accomplished, and along the anterior and posterior margins you can see some blood products there which you often see after surgery. Unfortunately, the diagnosis for this was not a low-grade glioma, and it was an anaplastic astrocytoma, which is a grade 3 astrocytoma, and so this is a high-grade glioma. So then we're going to segue into post-therapy monitoring now. Now with patients that are in the post-therapy setting, the treatment for high-grade glioma is maximal safe surgical resection with temozolomide chemoradiation. And then after that, close interval MRI follow-up is what is done. And in this case, you can see 3 months after the surgery, the patient did quite well. You can see that the surgical margins look very clean. And on the left, you have pre-contrast T1 weighted image. And on the right, you have a post-contrast T1 weighted imaging. You can see along the margins of the resection cavity, you see a little bit of linear contrast enhancement on the post-contrast enhanced scan. There's nothing really nodular about it, and this is just post-surgical appearance that you see that usually will resolve over time and is not concerning for any tumor progression at all. The patient did quite well and for several years was followed up with conventional MRI imaging. However, almost 3 years later, you see a small kidney bean-shaped area of nodular contrast enhancement actually anterior to the resection cavity in the right temporal lobe. This is concerning because progressive tumor can look like this. On the other hand, though, what confuses all this is that post-treatment radiation effect can also look exactly the same as contrast-enhancing tumor. Now, there are different ways of dealing with this. The conventional method is to follow with close interval follow-up. Now, if it's post-treatment radiation effect, then the contrast-enhancing lesion will either stabilize or it will disappear. If it's tumor, it's generally going to keep getting bigger and bigger and bigger. And as we can see on the very right, the contrast-enhancing lesion was starting to get very big, and the concern for tumor was very high. But at the same time, some of this could also be post-radiation effect, and we wanted to really be sure. Now, we at USC have been doing perfusion imaging for quite a while. It's an advanced imaging modality that has been around for many years. However, the way it's being, the way the images are required and the way that we post-process them has really changed a lot, and we're doing some of the most advanced techniques now at USC. And these are just some serial images just to show you what these images look like when we are acquiring the perfusion images. Now, perfusion MRI is a dynamic form of imaging as opposed to the conventional imaging that we saw, which is more like snapshots in time. This is actually kind of like a movie. And so we acquire very fast images before, during, and after the administration of a contrast agent. And this has many applications in brain tumors, from differentiating tumor from non-tumor, trying to differentiate different tumor types, trying to differentiate the grade of a tumor, and also biopsy guidance, and what we're talking about now, evaluation in the post-therapy setting. This dynamic susceptibility contrast method that uses T2 star weighting, some physics details that I won't really go into, is the most common method. This is the same method, by the way, that is used in stroke imaging. So the two major applications of this type of perfusion MRI is both in the evaluation of tumors and also in the evaluation of patients with acute stroke symptoms. Now, there is a metric that you'll hear. It's called RCBV, which stands for relative cerebral blood volume. And so this is the main number or value that we get from perfusion MRI that is most relevant to brain tumors. And higher numbers indicate a higher degree of aggressiveness and malignancy, and lower numbers indicate a lower grade or potentially post-treatment radiation effect. Basically, what you do is you take these rapid dynamic images, you look at changes in the signal intensity over time, and you do mathematical calculations with different algorithms that the different softwares have, and you get your relative cerebral volume measurements. However, one important thing to remember about it is this is all predicated on the idea that the lesion that you're evaluating doesn't have contrast enhancement. In other words, the blood-brain barrier is intact, and the dye that we injected is not leaking out into the lesion. But as we saw with this case of this post-therapy monitoring, we saw that there was contrast enhancement and that the dye was leaking out from the capillaries out into the extravascular, extracellular space. And this then can introduce some complications when we do relative cerebral blood volume measurements, and can affect the accuracy of these things. So the two situations that you can have, depending on what's going on at the biophysical level of the tumor, or you can either get underestimation or you can get overestimation of your relative cerebral blood volume, depending on what's going on locally at the cellular level. And to make things even more complicated, you can have both things going on when you get under and overestimation. And so this is a real troubling aspect of doing perfusion imaging in brain tumors that people have been working on for many years. This isn't really an issue in stroke imaging because in acute strokes, the lesions basically don't enhance. But in brain tumors, many brain tumors do enhance. And in the last few years, there's been more recognition of this lack of standardization with how people deal with this over the years. Perfusion imaging has been around for quite a while, but the way that people acquire the images and the way that people post-process the images has been quite variable. And so this has made it very difficult to use perfusion imaging routinely in clinical practice and in clinical trials because of the varied methodology by which this is being performed at. And I was part of the American Society of Functional Radiology white paper where we talked about this dilemma. In about 2015, we wrote this white paper talking about some of the major issues that are still remaining unanswered about how to do perfusion imaging for brain tumors. Now, most recently in the last year or two, my colleagues, Kathleen Schmeinda, Leland Hu, Jerry Boxerman, Chad Quarles, have been working on some both clinical and more radiologic physics level types of studies, trying to look at what are the optimal acquisition parameters for this type of perfusion imaging in brain tumors. And they've had some really good results with a standardized protocol that we have now adopted at USC just recently. I've completely overhauled all the brain tumor protocols here to adhere to these new acquisition parameters. So the images are acquired in a standardized way that's backed up by the literature. And then we're also using the latest post-processing software that can also compensate for that leakage effect I talked about in order to make the relative cerebral blood volume, the RCB values, as accurate as possible. And another real interesting outgrowth of this are what we call these FTB or fractional tumor burden maps. And so this is that same image of that patient I showed you where we were concerned about post-treatment radiation effect versus progressive tumor. We were suspecting progressive tumor, but we weren't quite sure how much of it was tumor and how much of it was post-treatment radiation effect. Before the advent of these FTB maps, we were very often given these RCBV color maps where we had an idea of where some hot areas were tumor, but generally we kind of characterize the entire lesion as either post-treatment radiation effect or tumor. Now in this case, you can see that a good deal of the area along the anterior margin is red, and red is an indication that it's tumor. You see some purple mixed in, which is an admixture saying that it's both post-treatment radiation effect and tumor. But posteriorly along that rim, along the rim of the resection cavity, you see that all that stuff around there is post-treatment radiation effect. And you can see to the left that histogram gives you a distribution of the number of voxels or pixels in that and shows you how much of that lesion is tumor versus mixture versus post-treatment radiation effect. And so then we're able to get a more nuanced view of this lesion. And so when we talk to our radiation oncology and neurosurgical colleagues, we're better able to tell them, look, this is not all tumor. There's some of it around the posterior margin, especially around the resection cavity, that looks like it's post-treatment radiation effect. However, if you're contemplating further surgery or radiation therapy, you really need to concentrate on that anterior aspect there. And this can give you higher confidence and really personalize the amount of therapy, personalize the therapeutic approach to each patient instead of just treating the whole thing as one entity. You can see that it's quite more complex than that. A couple of things I also want to mention are the advanced imaging techniques we utilize in pre-surgical planning. So very often you will have tumors that are located in areas that could affect their postoperative outcome. For example, the motor pathways in the brain are very often either infiltrated or displaced by tumors. Here on the very bottom, on the left of the image, you see this T2 weighted image where you see a very large hyperintense mass. And the big question for the neurosurgeons are, if they're going to resect this, where are the motor pathways? And in the middle and to the right, you see these diffusion tensor imaging images which show that the corticospinal tract, the motor pathway, is actually pushed over medially, and that the tumor is actually along the lateral aspect of the corticospinal tract. And so this gives the surgeon a lot of information, in that they should be very cautious as they proceed along the more medial aspect of this tumor. And so this, in addition to the conventional imaging, is something that we routinely utilize here to make sure that we have optimal outcomes after surgery. In addition to that, we also routinely perform functional MRI to act as a complement to the structural diffusion tensor imaging tractography images, to also look for where the motor areas are of the brain, and also language. And so in this case, to the very left, you see a large contrast enhancing lesion that could be near the motor strip for the patient. And then the slice in the middle shows a cut just above that area where there's still some low signal areas, that is the edema part of the tumor. And on the right is an activation map showing the patient tapping their fingers, showing where the motor strip is. And you can see it's right along the anterior aspect of that edema. And so this tells the patient, this tells the surgeon that when they go in to operate, that they need to be very conservative in that area in order to decrease the chances of any motor deficits after surgery. So I just want to give just a quick overview of some of the research areas that we're talking about with regards to brain tumors. We have a 7 Tesla MRI scanner here at USC, and in that picture in the upper right, you see them lowering in this massive scanner here. Most conventional clinical imaging is done at 1.5 or 3 Tesla. But 7 Tesla scanners are very powerful scanners. They're the most powerful clinical scanners in the world, and not many places have them. They're still primarily used in research applications. There's very little known about the use of 7 Tesla MRI in brain tumors, particularly with respect to advanced imaging like brain tumor perfusion imaging. And so we're undertaking a program to see what sort of advantages we can get with the higher spatial resolution you can get with this very, very powerful 7 Tesla MRI scanner. We're also embarking on a program using a technique called magnetic resonance elastography to determine how hard tumors are. For example, meningiomas can be very soft, or they can be very hard. And it's very important for the neurosurgeon to know what the consistency is before they go in and operate. This can help the patient understand what their expectations are with respect to how much of that tumor we can cut out, because if the tumor is rock hard, it may be very difficult to get it all out. On the other hand, if it's soft as jello, it's relatively straightforward to cut out the tumor in its entirety, and also have minimal blood loss. So that is a new area that we are working on, as well as trying to develop these FTB maps for metastasis. The FTB, the fractional tumor burden map that I showed you for that primary brain tumor, is relying on tissue samples taken from patients with glioblastoma and high-grade gliomas. On the other hand, metastasis, which are tumors that spread to the brain from other parts like breast cancer, lung cancer, and so on, the blood vessel physiology of that is very different from that of a primary brain tumor. And so we really need to understand what are the perfusion, the RCBB values of the blue post-treatment radiation effect, of the purple, that it's the admixture of post-treatment radiation effect, and the red, which is frank tumor. And we don't know that because the different primary tumors all have different physiology, and so we need to understand that. And so we're participating in a multi-center study with the developers of the FTV maps, the research colleagues that I talked about, and we're collecting cases, and we're trying to figure that out so we can create these maps for these different metastases. And finally, I am part of the Enigma consortium, which does the world's largest brain tumor or brain imaging studies that have ever been done. and I'm focusing on cancer-related cognitive impairment. And we're trying to collect cases from around the world of patients who have cancer that are not yet in the brain but are outside of the brain, to see what portions of the brain are affected structurally and also functionally, to determine the basis of cancer-related cognitive impairment. One major aspect that people may have heard about is chemobrain. So people have this fog, either temporarily or long-lasting, after they survive cancer and they undergo chemotherapy and other kinds of cancer therapy, but have problems coming back to the normal with regard to their cognitive functioning. And this is all in partnership with the other institutes at USC, like the Stevens Neuroimaging Institute, the Imaging Genetics Center, and the UK Biobank, and also some of the funding has been obtained from the NIH. So in conclusion, I think I've given you an overview of the brain tumor imaging program we have here at USC. I've gone over the use of neuroradiology and brain tumor diagnosis, and I spent quite a bit of time dealing with the critical role that neuroimaging has in post-therapy monitoring, and I've highlighted some of the unique aspects of the advanced imaging programs here at USC, with particular respect to the fractional tumor burden maps that we now have, which we've just added here at USC, as well as some of the pre-surgical planning with respect to the diffusion tensor imaging and the functional MRI that we can do to optimize the safety of the brain tumor surgeries. These are all an effort in order to personalize the brain tumor imaging for each patient and not treat all brain tumor patients as if they're one sort of monolith. And at the very end here, I just want to thank my colleagues here at the USC Brain Tumor Center and my colleagues at the USC Division of Neuroradiology, my research collaborators. And last but not least, I want to thank the patients and their families. I personally have had some close family relatives who are cancer survivors, and I realize the devastating impact that having a cancer diagnosis can have on a patient. And I think we all here at USC are doing our very best to do whatever we can to ensure that you have the best outcomes. And I am leaving my email here if you have any questions about our program, or in particular the neuroimaging brain tumor program we have here. Please feel free to reach out for me. Thanks for your attention.